You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
In this episode, I'm speaking with Kunle Ogungbemi about ischemic stroke care and the innovation of thrombectomy. So what I want to do is really have this conversation for a while actually around why thrombectomy is considered a leading stroke intervention and how it can contribute to early rehabilitation, improve functional outcome and indeed treatment of stroke. So what we look at in the episode is how it can restore cerebral blood flow. We look at the functional recovery of patients undergoing thrombectomy. We look at the minimal invasive approach thrombectomy takes. We look at the collaborative care and how much it actually takes to provide a 24/7 service. And then some of the positive clinical trials showing its effectiveness. So I really wanted to have this conversation for a while, and Kunle has kindly obliged, and he proposed quite a novel approach actually to stroke care, and this is this hub and spoke model for thrombectomy services. So the hub being the thrombectomy itself and the spoke being the hyperacute stroke unit or HASU. So what happens is from the spokes and from multiple spokes depending where you are geographically, they get prompt CT scans and indeed a package of care at the spoke, and then they get promptly transferred to the hub, so to thrombectomy for definitive care. So data suggests that for every 9-minute delay in onset to reperfusion, 1 in 100 patients will have more severe disability at 90 days. So it really does call for the need for both confirmation of stroke caused by LVO or large vessel occlusion, and then the rapid transfer to thrombectomy centres. So please do enjoy this wide-ranging conversation with Kunle. This is really a game-changing intervention. He really speaks to the number needed to treat and the drastic change in functional outcome, even on the table, so even whilst these patients are having thrombectomy. So here's my wide-ranging conversation with Kunle, and I hope you enjoy. Now, I wonder if we could just start by getting you to speak to how innovative this approach has become in practice, and just maybe because it appears to be sort of an analog of PCI, but for the brain.
Yes, that's. I think that is a very reasonable description. Thrombectomy, which is what we're talking about, effectively involves going in a minimal invasive way, patients with a stroke, which is typically a blockage in one of the blood vessels in the brain, and taking the clot out. It's been an absolute revolution in medicine. I don't think it's an exaggeration to say it's one of the most impactful and effective treatments to date in modern medicine. It has made a massive difference in the treatment of stroke patients, and it's certainly something that should be much wider known and should be better available, particularly in the UK, where I think we're a little bit behind what's happening in Europe.
So we just spoke offline actually, Kunle, about the availability and indeed the awareness of thrombectomy. But could you maybe speak to how it indeed restores blood flow and how it sort of differentiated from what would maybe have been previously sort of clot lysis?
Right. So yeah. So that's right. So historically, what we had with patients who had a stroke, or what we're talking about, an ischemic stroke, which is a blockage in the brain. Well, historically, we didn't really have very much other than rehabilitation. Then several decades ago, a treatment, which is the clot-busting drug you mentioned, came along, and it works reasonably well, particularly in patients with the smaller, less disabling strokes. But for the larger, really disabling stroke, its effectiveness is much reduced. Then, just over sort of a decade ago, we started to realize the effectiveness of thrombectomy, which is a minimal invasive procedure where we go in and actually take the clot out. And to address your question, if I could give you examples, because you mentioned the PCI, which is the percutaneous coronary intervention, so people who have a heart attack and they have to be rushed into hospital, and then people go in a minimal invasive way, similar to what we do, and take the clot out. Now, that is very well known. Everybody would agree it's a great treatment and should be widely available, which it is. But just to point out, the actual way we measure effectiveness of some of these treatments is something called number needed to treat, or NNT. What that means is you take a treatment and you compare it with what already exists, and you see how many people you would need to treat in order to save either one life or save one person from a severe disability. When you're talking about PCI, you're talking about a number needed to treat of 1 in 40. So in order to save one person, you would need to treat 40. Now, you compare that with thrombectomy, which is way less widely known or available as PCI, and the number you need to treat to save one person is between 2 and 3. So it's incredibly more effective and makes massive difference to lives. With the clot busting drug we had, which I mentioned was a very good treatment, you're still talking about a number needed to treat of something like 11, 12. So you will still need to treat 12 people to get the same result you would treating 2 or 3 with thrombectomy. So it really is that powerful. I'll give you more examples. I mentioned earlier at the start of your program that it's no exaggeration to say it's one of the most effective treatments we have in medicine. And when you look at some of the most effective treatments that we've discovered in medicine to date, there are surprisingly few that beat this number needed to treat that we're able to get for thrombectomy. I mean, you're really in the realms of triple therapy for peptic ulcer disease, antibiotics for sepsis, and then you're really scraping on the bottom of the barrel to find something that's more powerful than this. So it really is that powerful and that important. And I think, yes, your blog and things like what you were doing and some of the Stroke Association and people out there trying to do to spread the word, I think is really critical.
It's fantastic just to hear you speak, actually, Kunle, because, like you said, it's a revelational treatment, and also just looking at the downstream effects, because, like you said, the number needed to treat is so low, but also the downstream effects of time to rehabilitation, and indeed, personnel, the actual clinical staff needed to, and also bed availability, and the rehabilitation staff in stroke wards and stroke units. Could you maybe speak to sort of the second and third order effects of the treatment?
Yeah, that's absolutely right. I mean, when we talk about thrombectomy, obviously we're talking about this minimally invasive treatment, but there is a whole host of staff that are absolutely critical in getting this done, starting with the patients themselves and their families being able to recognize, the symptoms that we're talking about. So we have the FAST campaign that's been, really effective, and people knowing, because, like you said, time is absolutely critical here. So that really starts from educating the public to knowing what to look for, and to knowing that this treatment is available and will be more effective the faster they can get to us. Then you're talking about the paramedics, who also need to know and absolutely critical in the process, because they will be the ones to get to the patients and take them to the hospital as quickly as possible, and understanding the time critical nature of this for paramedics becomes absolutely paramount. I think we're very good with that when it comes to, for example, trauma. I think a lot of paramedics understand, the concept of the golden hour and the need to get people rapidly. But, I think something like that certainly needs to be developed for thrombectomy as well. Then you talk about local hospitals with the initial clinicians who need to assess the patient, start the really important initial treatment, and then get them to the hub, if you like. We're talking about the hub and spoke model, as quickly as possible so that we can do this treatment. But that's not the end of it. After that, then they have to be looked after by our stroke physician colleagues who run the hyperacute stroke units. And we know that stroke patients that are looked after in places like this do better. And then there is a long process after that of sometimes months of rehabilitative language therapists, neuro rehab specialists who also play a role in getting these sort of wonderful outcomes that we can get with thrombectomy. But it is absolutely critical, and there's no doubt. I mean, people have looked at the cost effectiveness of this in terms of, you know, reduced disability, getting people back to work, and its ability to get people back to a functional independence so that they're back with their families and contributing to society, if you like, and in the economy. And it's a no-brainer. I mean, no pun intended.
So looking at, you know, where we could play a role, so where, you know, paramedics and pre-hospital care can play a role. Like you said before, there's been some fantastic campaigns about fast tests, and indeed public awareness, which is key initially, because minutes equals neurons, and that can really contribute to morbidity. Could you maybe unpack sort of where you see the role for paramedics? Because I think in the hub and spoke model you proposed, it really is about early awareness, early identification, and then getting them to a place where you can have a prompt CT scan. We spoke offline about the certain innovations, certain ambulance services, London Ambulance Service, are trying to keep the ambulance crew with the patient, so to try and cleave and leverage the downtime so that you can start to narrow this time to thrombectomy, because minutes equals neurons equals functional ability or disability, equals worse or better rehabilitation times. Could you maybe speak to that pre-hospital piece and where you see the leverage, where you see the gains?
Sure, yeah, absolutely. I mean, I think the role of the paramedic team is absolutely critical in this. I mean, if you think about what we're talking about, of, you know, minutes equaling, you know, neurons, and the number of neurons you lose potentially for every minute delay, and you think of a patient who's at home and has just had this stroke, and where those delays can be. Just before I get to that, just so you sort of understand the context, I mean, the average time, so at St. George's Hospital, we have had the longest running 24/7 thrombectomy service in the country, and we've got it down to when a patient comes into our angio suite, from the moment we puncture the groin, which is how we access to the time when we take the clot out, we're talking 20-30 minutes. All right, and so you know, we're managing to cut that time, and there is still room for improvement, and we still work on that. But then you think about how long it potentially takes for a patient to be picked up at home and actually to get to us. You know, that can be hours. And so if there's going to be a huge amount of gain, actually engaging our paramedic colleagues and with, you know, educational programs, if you like, such as these, is absolutely critical. It's been a learning process for us all, and one of the things we realized when we started, there've been lots of, you know, things that we've learned along the ways in terms of, and one of that was actually the importance of educating or spreading the gospel, if you like, of what we're doing and why we're doing it to our paramedic colleagues. We recognized that almost right away when we started 24/7 service, and in fact, one of the things we started doing, which, you know, some of the paramedic bosses might not thank me for, might be spilling too much here, is actually encouraging the paramedics, once they brought the patients to the thrombectomy suite, to stay and watch behind the angio suite and actually watch the whole procedure and see the outcomes. Because not infrequently we get patients who come in and they're completely paralyzed on one side, they can't speak, they can't talk, they can't move anything, and we take the clot out, and within seconds they're moving and talking. So, you know, I think for them being able to see that, you know, it really helps with the process. And next time there is a stroke that they're involved with, and they know what we potentially can do, I think all these things sort of help with speeding up the process, and that's really what we're talking about, time.
I think that's really powerful for learning and experientially for paramedics, because like you said, to be able to see the difference you've made and to be able to tangibly see the outputs and the outcome and that functional ability return to the patient is profound, actually. But Kunal, could you maybe speak to just there's lots of unseen components, as you were speaking to before, about just the logistics of operating a 24/7 service, and I'm sure there'll be people listening to this thinking, what can we do in this space, either pre-hospitally or hospitally, to bring a service closer to fruition, a thrombectomy service, and close the gap, close those little moments in time, those minutes and or hours. Could you maybe speak to the logistical and or team efforts that it takes to run a 24/7 thrombectomy service, and maybe, like you said before, some of the learning you've cleaved from that time, because even now I think there's continual improvement and you're continually sort of leveraging those gaps in delivery of service.
Yeah, I mean, it certainly, I mean, it goes without saying, it is challenging. I've just touched very briefly on some of the professionals and staff that are involved in running it 24/7, but there's a whole host of equally critical people that, I should definitely mention, our neuro nurses, our radiographers, the porters that help us move. It's a whole host of people. It's a complex machine, and all working under tremendous time pressure, right? So a lot of the learning is actually about that, of how you cut these delays and these gaps, and where you can gain efficiencies. And again, it always comes down to the same thing: education about what we're doing, why we're doing it, and what it can actually achieve. And as you mentioned, it is actually surprising. Well, perhaps not surprising, but it's a very powerful motivator for people when they understand that, and they can see, the outcome for somebody who gets to you on time against somebody who unfortunately doesn't. So I think getting as much awareness, putting political pressure, if you like, so that the resources to provide these services can be made available. Sharing learning. I was talking about some things we learned. I mean, one of the interesting things that relates to paramedics, for example, is when we first started a 24/7 service, we noticed that, if a patient had a stroke out in the community and were coming to us, it would be pretty reasonably rapid. Obviously always room for improvement, but definitely rapid. But if a patient was already at a hospital, so they had a stroke and they were taken to a district general hospital, and we needed that patient to come across to us, it took much longer, and it was quite confusing. And of course, then we then found out, having talked to our paramedic colleagues, we find out about this system they have of patients who are considered to already be in a place of safety against patients who are out in the community. And of course, that again came from just a lack of understanding as to what we're doing and why we're doing it, and why this was even different to PCIs, which is probably what they had to compare it to. But this was actually different. This is more like a life critical, life changing procedure that needed to happen. So they needed to be just as quick. And so we did a lot of work with the paramedic teams in London to actually change this, and change how patients who are wherever they are with a stroke are categorized. So it is little things like that, sharing this learning, and just finding areas where we can cut the time and the delays.
Absolutely. And like you said, it's all the nuances and subtleties that aren't abundantly apparent initially, which is, like you said, the AMPDS code, so the coding in the ambulance service, which prioritizes the call to the district general hospital to retrieve the patient, and making sure that is a Cat A or a priority 1 call. So, like you say, cutting down on all these system-based errors or system-based interventions, so that you can get the patient to you a lot quicker. Kunle, I just wonder if we could just focus slightly on the hub and spoke model, because the paper was published in 2021. And you took a cohort and indeed ran it through an ambulance service with a number of HASUs, hyperacute stroke units, and then the thrombectomy service. Really interesting that more than half of the workload you saw was actually at nighttime, out of hours, out of normal hours, which again speaks to the mandate and the necessity of 24/7 stroke care, because rarely does it happen in normal office hours. It happens around the clock. But could you speak to what you found from that study, and maybe what the downstream effects now are from that study?
Yeah. I mean, it is it is interesting that you talked about that, because you're absolutely right in terms of when strokes happen or thrombectomies happen. When we were talking about going or having the 24/7 thrombectomy service, one of the assumed wisdoms, if you like, or conventional wisdom, was that strokes don't really happen in the middle of the night. If you're going to have it, it's going to be during the day when you're up and about. So we thought, well, it probably won't happen that much at night. It's obviously when you're awake and during the day. But how wrong we were. The vast majority do happen, at night. So absolutely critical that there is a 24/7 service available everywhere, frankly. I mean, I think it's we are, say, behind the curve on that. But in the UK, and certainly in St George's, what we did start was this hub and spoke model. And if I just tell you a bit about that, what that means is you have a hub, which is what we call a comprehensive stroke center, which is where we have the ability to do all the usual stroke treatments, plus have the neurosurgical cover, and do this thrombectomy. And then you have the spokes, which are hyperacute stroke units that are typically smaller hospitals, but do have the ability to give the initial treatment, and then get the patient to us in the hub. And it's a model that works quite well, but what it does throw up is a whole, again, host of issues that you don't initially recognize. For example, the types of scans that you need. You'll find different hospitals do different things. The protocols that you use, who looks at the scans, the processes of getting a patient transferred to that, from that hospital to there. So trying to standardize everything that you're doing, and getting everybody on the same page, as it were. Then of course you have the issues of then repatriating the patients as quickly as you can back to the hospital, so that you have the capacity to keep taking more. A whole host of things that you don't actually necessarily think about, and why would you, until you actually start doing it. So it is an interesting model, and one that works quite well, but certainly a lot of room for improvement. Yeah.
Now, could you speak to what's next in this space? What are you working on now? And indeed, what would you like to see from pre-hospital clinicians and or ambulance services, more so?
Well, yes, I mean, so thrombectomy is there is absolutely no stopping it. I think fortunately or unfortunately, depending on your perspective, but certainly fortunately for the patients, for sure. There are lots of trials that every year there's a whole host of new trials and the trend is inexorably in the same direction. The indication, so the number of people that we can and should be offering this treatment to, just keeps on expanding. So it used to be that we could offer the treatment with patients presenting within 4.5 hours. Then trials took that to 6. Then trials took that to 12. Now there are trials that have shown benefit up to 24 hours and beyond. For being able to access thrombectomy. You also have trials that have actually, now the latest trials have looked at patients who in the past we would probably have thought they probably won't benefit, because these are patients who already have what looks to be a very large completed infarct. Because one thing you don't want to do is to be reopening the blood vessel to dead brain, or at least so we thought. But then trials have now come and looked at that and actually found that for a significant proportion of these patients, there is still clear benefit to offering thrombectomy, as against to the current best medical management. So that's only just come out this year, and that's already massively revolutionizing what we do. There's another trial that's being run out of Canada, which we at St. George's are also leading on for the UK, which is now looking at the benefit of thrombectomy in much smaller vessels. So smaller vessels that we, might not have looked at before, we weren't really sure of. So there are now trials actively looking at whether or not thrombectomy will benefit patients with these. So the trend is clear. This is here. It's here to stay. It's expanding, and the impetus to make this available and as widespread as possible is irresistible.
Yeah, that's fantastic to hear that, actually, because a number of things are happening as well in the landscape of air ambulance charities and indeed air ambulance services. So Norwegian Air Ambulance are one of the first to put a CT scanner, which apparently weighs only 50 kilograms, into their aircraft. And so what they can do is really start to target some of these from source, so from call taking, and fly the aircraft out. And then I guess once they've confirmed it is an ischemic stroke, they could fly straight to thrombectomy. So we're starting to see, with the evolution of smaller technology and more compact technology, that we're starting to get more point of care, at least diagnosis, and so we can start to stream to thrombectomy centers. So it really is quite exciting, the innovation in this area. And like you said, the time window leverage is fantastic. So actually the 24 hours still shows benefit, and looking at that is a fantastic innovation. Kunle, as we start to come into land, could I get you to speak to just some of the salient lessons and or future importance within stroke care that you could speak to? Sort of where do you see us going versus the US? Say us being the UK and or Europe. Is this something which you're going to start to see as extremely commonplace, and indeed maybe we'll start to replace more traditional approaches to stroke care?
Yes, I mean, I think it's a good question. I mean, I think like I said at the earlier part of this talk, the UK unfortunately is still lagging some way behind certainly America and large parts of Europe as well, in terms of access to thrombectomy and provision of round-the-clock uniform level of service. I think in London we're pretty much there, but large parts of the UK unfortunately are not quite there. But yes, there are absolutely revolutionary things that mean that this gap will be or should be easier to close than might have been, say, 5-6 years ago. One of those things, for example, is the use of AI. At St. George's, so that's one of the things we developed with our hub and spoke model, was actually part of what I touched on as to the difficulty in standardizing what imaging and who reads it, and actually implementing an AI, which was a service which was run by St. George's or sponsored by us, and actually giving access to all our spokes of this, so that everybody does the same scan. The scans are interpreted by the AI, and everybody on the service that day gets the same images, the same picture, and the same results, and then can take it from there. And that streamlines things a lot. It makes a lot of the spokes far more comfortable, because of course part of the difficulty with starting these services will be in people concerned about lacking the relevant skills, if you like, to look at these images, to interpret these images and perform them. So you're able to remove something like that. So I think that there is that trend for AI to help geographically as well. I think England or the UK, if you like, is in some ways smaller than, say, Australia or the US. So there are potential advantages there in terms of actually leapfrogging by the sort of things we're talking about, streamlining our logistics. Not every thing we need to do needs to be AI or high tech, but just even simple things like this, streamlining our services, arranging or implementing redundancies in the system. So if one place goes down, another is able to cover. I think those are some of the advantages that we could have geographically, and we should be looking to implement. But I think, yes, for now, unfortunately, our priority should be to catch up with Europe and then the US, and then hopefully from there really get the advantages we have ticking.
Listen, that's fantastic and a great place to leave the conversation. Thank you so much for the last half an hour. It's been extremely informative, and I can really see this intervention becoming absolutely fundamental within not just within stroke care, but also within the wider neurorehabilitation. And like you said, it's going to be extremely exciting to see where these future clinical trials point to. So thank you again for your time.
Pleasure.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.